We hope that you will enjoy this presentation, Finding a Manageable and Effective Bowel Management Program, a session for families. This session was recorded at the 2010 Spina Bifida Learning Conference hosted by the Spina Bifida Association of Alabama and the Children's Hospital of Alabama. Please be sure to take time to complete the evaluation at the close of the presentation.
A lot of people don't want to address it. That's the secret go in the bathroom thing. But we all need to really listen to what she has to say, because it will change your child's life or your adult's life or your friends or whatever the relationship is. It's really important. So
here you are, you agree.
I went to, earlier this week, you know how you plan things and they all happen in 1 week? Well, earlier this week I was at Duke talking to some young girls, and I wanted to make an impression on them. These were anywhere from 8 to 17-year-old girls that had spina bifida. And so I wanted to drive home the fact that our culture is very tuned in to hygiene and cleanliness. And so I wanted it to be recent. So I went out and I bought a 17 magazine. This is actually this month, September 17 magazine. And I looked to see if things had changed since I did this about 20 years ago, and they have not. There were no less than 40 plus either half-page or full-page ads that had to do with hygiene, hair, beauty. And I didn't even count the makeups and dresses and things like that. Being clean and smelling good and looking fresh. I particularly love this one. It's a deodorant commercial about sports and about tennis. And this is Two Left Feet Meet School Heartthrob is the title of this. And it's the degree deodorant that makes the difference. That is true for everybody. That's not true for just people with spina bifida. That is a big push in our country. I had an exchange student that was at my sister's house from Germany, and he would go to football practice and come in and just reek and just change his clothes and come to the supper table. And so my brother-in-law said, you know, Max, you got to hit the showers. And he said, you know, it's over there. And he said, no, I mean, you have to hit the shower now. You have to go take a bath. We can't stand it. And he got up from the table and he said, you Americans just have this thing about cleanliness. And we do. In our culture, in our country, if you want to be accepted and be the choice of somebody to sit by or be a coworker with, you can't smell bad in our culture. And you say, but there are extra challenges when you have a disability, and it's not fair. And that's correct. It's not fair. And having spinal bifida isn't fair. And you're also correct, there are extra challenges, but they're not challenges that you can't overcome. I keep saying I'm going to quit this little illustration, and yet I cannot find anything that says it any better than this. And that is that continence is a self-preservation mechanism. When big animals stalk little animals and hunt them, if the little animal urinates or defecates at an inopportune time, they are quickly detected and devoured. Enter another group of predators, if you would. If you send your child into the school setting, especially first and second grade, when bathroom jokes are the big issue, and you know you want to say something to really make somebody mad, you say you wet your pants, or you have to wear diapers. It's just like throwing them to the leopards or to the wolves, if you would, because they need a way. They're going to be competitive, and they're going to be able to stand up, take their place, take their turn. Then they need to have a way to privately control their bowel and bladder. It doesn't have to be the way everybody else goes that we've been saying, but it has to be a way that they can. I want us all to get on the same page, so I want to preface my talk a little bit with talking about the fact that there's 3 bathroom personalities, and you're all sitting in this room. The first type of bathroom personality is a bathroom personality A. And these are people that are very predictable. They're very boring, but if you ask somebody, when did you go to the bathroom? They'll go, about 7:30 this morning, like I always do. I get up, I have my coffee, I go to the John. They don't have spinal bifida. They don't have anything wrong with them. They're just that predictable. And unless they do something like get a virus or take a trip, They just pretty much know when they're going to go to the bathroom. I am not one of those kind of people, but they exist. Then there's bathroom personality B. And these are people who might go to the bathroom one time today, they might go 2 times tomorrow, they might skip a day. They've got good muscles, they've got good sensation. It really doesn't matter to them when they go to the bathroom, and it really doesn't matter to us. And it's fine to be a bathroom personality B if you have sensation and good muscles and access to a bathroom. But unfortunately, there's bathroom personality C, and nobody wants to be a C. There's this bathroom personality entails different people. When I first got out of nursing school, when you are low man on the totem pole, they put you on whatever floors they want to, and they put me on a little old lady's floor. I'm old enough that they used to have women's and men's floor in general hospitals. That's not a lie. And you had to be over 90 and have a broken hip to get on this floor. And my very first job, which should have told me that a few years later I would end up doing what I did for the majority of my career, was the bowel cart. And there was actually a cart, and it had suppositories, laxatives, enemas, and all that on it. And you would push the cart down, just like the hostess with the mostess, and you'd push it down and go in a room and go in and ask the person how they were doing. And they would say to me, I haven't gone to the bathroom yet. I mean, here it is, 7 o'clock in the morning, and they were already focused on that. And they were not going to quit till they already got that over with and checked off their list, and then they could go on. Bathroom personality C also are people who have a spastic colon, if you've heard people say, or trouble with their gallbladder, and they're the people that are in the menus looking for the thing that won't upset their stomach when they go out to eat. They look for something, no, that might, better not pick that. And their bowel and their bathroom habits kind of begin to interfere with their life. Nobody wants to be a C. Someone who is paralyzed, has spinal bifida, spinal cord injury, or whatever, that doesn't have sensation and that doesn't know when it's going to happen, will be a bathroom personality C, unless we turn them into an A. Now, there's a few people that are fortunate enough to be A, and they're predictable, and they can go, and they're not the people that have to have bowel programs. But anyone who doesn't, we fool with Mother Nature, and we make them into an A, a very predictable, boring, hopefully, personality. Do you know that complicated slide that Dr. Joseph had that had all the nerves and everything? This is mine for bowel. I don't want anybody leaving without understanding how you go to the bathroom, because if you can understand how you go to the bathroom when your nerves work well, you can understand how you go to the bathroom if they don't. When you eat food and it goes to the stomach, it's kind of churned up, if you would. There's not a lot of absorption that takes place. And then it goes down through your 26 foot of small intestines or whatever, and they take out most of the nutrients. And then when we get interested in it is when it goes into the colon and down and actually begins to collect in the lower vault, the rectal vault, the lower part of the colon. And all of this is taking place. You don't have no awareness of it. You don't go, oh, my lunch just took a turn down the second third of my small intestines. You don't. All this happens, and with people with spinal bifida, until you get down to this area we're talking about. Now, what happens in people who have normal sensation is the waste or the stool begins to collect and collect and collect. And when it gets a certain mass, a certain bigness, it sets off stretch receptors in the wall of the colon. The stretch receptors send a message to the cord sends a reflex back, and you've got 2 sphincter muscles. You've got an internal sphincter and an external sphincter. And when that message goes to the cord and comes back, your internal sphincter, it tells it to relax. It relaxes, and that stool presses on the external sphincter. When that happens, you and I go, oh, I think I need to go to the bathroom. It's a very sensitive, it's like a microchip. It tells you whether it's liquid or solid or gas. If it didn't, every time we were going to have a toot, we'd go flying to the bathroom. But you can sense it, and you can tell, and then you can get by with that and move along. But if you can tell, too, if it's liquid, it can tell, and you know, instead of ambling that way, you need to beat the feet that way. When you go and sit down, it's interesting. When you go to urinate, Dr. Joseph was telling you, you relax to urinate. The opposite you do with the bowel. You have to push to initiate the bowel. If you relax from your bowel, nothing happens. So what you do is you go, you sit down at a socially convenient time. That's Stool presses on the outside of the ones. You push down, it opens and dilates that external, your anal sphincter, and the stool comes out. Now what if you have spinal bifida? All of that happens, like we said, until you get down to the part where you go to the cord and you don't get a message back. The internal sphincter doesn't relax. You have no sensation of the external, the stool's pressing on the external sphincter, and so it just collects and collects and collects. By far, even though everybody does it, by far, constipation is the problem with spinal bifida. Occasionally, I've had kids that have trouble with diarrhea and have an open sphincter and everything comes, but by far, constipation is the usual culprit in spinal bifida. I want to have another illustration. This is my son-in-law, and it's a bone of contention between my daughter and him about the trash. My daughter wants to have a little trash can that's taken out more frequently. Alex was in the Marines, and he wants a big trash can that he can just take out once a week because he thinks it's foolish to be making trips outside to the trash, you know. Well, the problem with that is that when you have a big trash can and you fill it up with a lot of trash and you keep it for a week, it gets smelly, it gets packed down, it gets very unpleasant. So when you go in to go put some clothes in the dryer, you open the door, hold your breath, shove them in the dryer, close it, and run back outside. With spinal bifida, that's the same thing when you have someone that doesn't go to the bathroom but once a week or once every 2 weeks. In fact, it also will affect your health because the garbage can grow and grow and grow until you have a huge problem, not just a bigger trash can to take out, if you would, but something you can't handle. And you actually can begin to lose your appetite, get sick, run a fever. You can even have an impaction and end up in the ER with that. So you have to really understand the need for turning things over. I'm going to talk a little bit about constipation because that's the first step when you're doing bowel management is to get rid of your constipation. So if you're starting or wanting to start a bowel program and you have a significant problem with constipation, you need to address that first. Just only having a stool every 3 days doesn't necessarily mean you're constipated, but if you have hard, dry stool that's difficult to pass, then you have constipation. Constipation can make you not eat well. Constipation is also a risk for colon cancer as you get older. It's not healthy to be continually constipated for anybody, whether you've got spinal bifida or not. Stool consistency, timing, and motivation are the 3 components to a bowel program after you get rid of the constipation. And we'll talk about ways to do that. There are general things for good health that you ought to do for constipation or for bowel health. One is to make sure you have taken enough fiber. Children don't usually eat a lot of fiber, but neither do teenagers and very few adults unless you're very conscious effort to do that. Up to about 35, and now it's to 40 grams. The recommendations are age plus 5. So if you have an 8-year-old, they would need to be getting at least 13 grams of fiber a day. If you have a 5-year-old, you need to be having 10 grams of fiber a day. If you're an adult like we are, you need 30, and now they say up to 40 grams a day. You'd be surprised the things that do and don't have fiber in them. This is a picture of foods that are increased in fiber. They're like the fruits with peelings on them. They're like nuts and whole grain foods. If you want a picture of what makes children with spinal bifida gag, that's also the same slide, because textures are not tolerated well. I even have little kids that have a hard time making that transition into solid food, and the parents think, well, there's something wrong with them. They'll get there and they'll be able to eat things like that, but textures are not. The gag reflex is sensitive with the Chiari, and so the exact foods that you need to be pushing for bowel health are the ones that they're probably least want to take. The things, on the other hand, that make the stool firmer are your simple sugars, cheese, macaroni and cheese, which has to be the favorite of all of the children that I work with, secondary to chicken nuggets. Fruit without the peeling on it and with sugar. Low-fat milk, which we want them to have for their weight gains and those types of things, and any of your sugars like cookies and things like that. So those are the things that they like, and those are the things that work against you if you're trying to get rid of your constipation. A good rule of thumb is to limit as many white foods as you can, and that's good for all of us, for our heart and exercise as well as for our bowel health. You need enough water, but what I found out is that you can't drink enough water can change your stool consistency. You can drink enough water to make you have to cath more frequently than you do. Some people say, how much water do you need? And there's this is what's in the literature and that's out there that you need. But I'll tell you, I think people need different amounts of water. I think some people might need more water than other people. You know if you're getting enough water if you can read a newspaper through your urine. If you think your kids are getting enough water and they still have dark urine that you can't really see, it's not light enough, then you probably they're not hydrated well enough. If you say, well, my daughter or my son or myself, I can't drink any more water, I'm drinking enough, and your urine's pretty clear and light colored and you can see, you probably are hydrated enough. But most of the people that I know, most of my patients that I talk to, just don't drink enough fluid. Water is preferable for the gut. Things with sugar and caffeine gravitate more to your kidneys, so things that are majority of water, and it can be flavored water, stay in your gut and help with your constipation. Exercise is important. The adult with spinal bifida that I stayed with when I went to Duke that's heading up this program recently did the Susan Komen Breast 60-mile walk. She did it in her chair. And it was over several days to do that. But she trained 400 miles getting ready for that event. And she said, when I was training and doing that, and when I took that, she said, my bowel programs went away. She said, when I got moving, so did my whole body and my whole system. So being active, keeping your young person or keeping yourself active is one other thing that really helps with the constipation problem and with the bowel. It says how you choose to go to the bathroom is a very personal matter. The secret is to keep it that way. But I tell young people when I work with them, I said, you know, I've never been anywhere, to a party, to church, to a conference or anywhere where somebody comes up and says, how do you do so-and-so, whatever, whatever. How do you go to the bathroom? We don't ask each other that. That doesn't come up. How you go to the bathroom is your own business. The only time that comes up is when it's not your own business. Now, if you're in a group of people and you leak a little bit of urine onto a pad, nobody's going to know that. They don't have any way to know that. Now, if you don't change tins all day and you begin to smell, that's one thing. But a little leak in urine, a little bit here, a little bit there, you can't tell it. But if you're sitting in a classroom and you have a little bowel accident, it doesn't take long for your neighbor and then the person in front and then the whole class to know something's up. And your bathroom, which is a personal matter of going to the bathroom, has now become not personal. It's become other people's business because they detect that. And so what you do is you manage your bowel at the time on your schedule when you want to go, how best you can do it, and then nobody asks you how you go to the bathroom. They might, after you get to be teenagers and you get on, because I've had other teenagers say, I want to know something, you're in a chair, how do you go to the bathroom? It might come up like that. But out in life and in general, it's your own personal business if you keep it that way. The question comes up is, how important is continence? And then you want to say, yours or mine? And I've asked physicians that a lot of times when they'd say, I was doing a study one time to see if I was making progress with my population, and I had set the criteria that one would be to qualify to say that you were on a good bowel program, you would have to have less than one accident every 2 weeks. And my chief of staff said, don't you think that's, given that you're working with people with neurogenic bowel, don't you think that's a little stiff criteria? And I said, well, how many accidents would you be willing to have every 2 weeks? Well, he wouldn't be willing to have any. And I wouldn't be willing to have any, and I thought even one every 2 weeks wasn't a very high criteria. And so it changes when you look at it, because I don't want my kids or young people with spinal bifida to expect that they're going to have bowel accidents. I want them to expect that they're not going to have it. Before we talk, and two more things I need to tell you about stool consistency before we get to talking about methods of bowel management. And that is that the stool consistency depends on the type of program that you have. Different types of programs do better with different stool consistencies. If you are going to try to do a suppository program, the stool needs to be more bulked and stick together. If you're going to try to do a cone irrigation, and we'll talk about those, it needs to be a softer, kind of grainy, almost like oatmeal consistency stool. So your stool consistency and what you take to keep it that way has a lot to do with what program you decide on. The second thing I want to tell you is an illustration. This is my older sister, Susan. I have two sisters, an older one and a younger one. We're all three nurses. And this is my sister's first fruitcake that she made after she was married. And this is my dad. And I was looking at this, and when I first started in here, I went, that is just like bowel management, because Susan took the right amount of fruit, the right amount of fiber, she put the right things into that cake, and she beat it with a mixture, and she beat it well, but she left it in the oven a long, long time. And all of the moisture got out of that cake. And you could actually slice it, and it was like a wood chip, like a frisbee that you could throw across the front yard. She was not amused. Daddy was sawing it to see if in the inside, if there was some edible, cake on the inside. But there wasn't. The inside was a little hollowed out. It doesn't matter what you eat and what you take. If you don't turn that stool over and you say to somebody, well, how often do you go to the bathroom? And they say, it's about, probably 7 or 8 days. Then you don't have to ask them what the consistency of their stool is, because their stool's going to be hard. But before you jump on that stool consistency with some of the things or medications or things we talk about, if you change the frequency of it, the consistency may take care of itself. So there is a direct relationship between bowel transit time, how frequently the stool goes through the system, how fast it goes, and the stool consistency. And a lot of things that we take speed up that transition, and that's how it makes the stool softer. Because the longer it stays in your body, the drier and harder the stool gets. The faster it goes through, the softer it is. What a beautiful day. Garfield sniffed, stinging. He says, conk. And he says, it's not nice to fool with Mother Nature. But I differ with Garfield. Mother Nature is the person that gave us the bum deal to start with. And so to mess with her, to make your life better, I don't have a conscience about that. There's all kinds of things out on the market now, from something minor to major things that you can take to balance out things. There's fiber bars, and there's a fiber drink to add fiber to diet. There's powder fiber. There's pills you can take. There's chewable things. This is psyllium type products that you can take that are laxatives, but they are not a stimulant laxative. They're more of a fiber bulking laxatives that you can use. You can now get them in capsules. The only bad thing about taking capsules instead of drinking the drink is you have to take a lot of capsules. And so when you look at it, it says, and they were talking about cranberry, take 7 4 times a day. Oh, a lot of pills. Well, these will say things like that you take. Well, you can see on the bottom they have 5 in the picture, but they'll be take 3, 4, 5 at a time, and you don't have to do that with the drinks. They also come in chews. A lot of different ones come in chews that are easier for the kids to take. That's smart fiber. Veni fiber, you can mix it in, and it doesn't. It used to be that Metamucil, you'd get there, you get to the patient's bedside, you'd get the cup and you get that, and you do like this. You'd say, all right, are you ready? And then you're ready, and you go, shh, drink, and then have to gulp, 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 because the thicker it would get. Now they have them that don't make it thick, that you can't taste and you can't see. It's easy to add fiber now. There's pills, Equilactin and Mitralan are products that you chew that sort of go one way or the other. If you've got water in your stool, it kind of solidifies it and gels it. If you've got a hard stool, it pulls the water in. So if you have somebody that oscillates back and forth and you can't get them I call these kind of stool normalizers. Things like fruities or all fruit or things like that, or you can make your own by doing prunes and raisins and things in a blender and nuts. You can use those by the tablespoon. You don't have to eat prunes now. Did you know that? There's prune lax. I went and looked at the new things that were out. Sugar-free candy has either sorbitol or those other sugars that act like lactulose, and so if you eat those, if you have a child that has a real problem with constipation, they eat gummy bears. If you get ones with sorbitol in it, that'll help them. Lactulose has a lot of names. It is, you know how you used to tell your grandmother put Karo syrup in bottles when the baby's constipated? This works on the same mechanism as that, but it isn't picked up in the bloodstream. It's a non-absorbable sugar. It's by prescription only, and I think use that in liver disease and things like that, because I don't know exactly why it would be prescription. But lactulose is good if you've got somebody that doesn't drink well. But the thing that you have to do if you're going to use lactulose is you need to start slow and not at a time when you're already constipated, because it makes a lot of gas and trouble if you do, and people will quit. But it's successful to use, and a lot of times we'll add it to babies' bottles if the fiber doesn't work. Milk of magnesia, even though it's an old-timey drug, is one of the best things you can use for long-term treatment. The PDGI people, when I talk to them, it doesn't cramp. In low doses, it's like a stool softener. It comes in a lot of different, it comes in chews, it comes in chewable tablets, it comes in liquid, it comes in whatever. It will move stool along a little bit, and it's easy to titrate. A lot of times, if I have to use something to get somebody started in that way, I'll pick milk of magnesia if I can get it in them. Now, this was in Dallas at the Spinal Bifida Convention several years ago, and the reason that we took that picture is that mineral oil is what is in that ball, and we would laugh and we said, that's the bowel ball. It's got mineral oil in it. I used to not ever prescribe mineral oil because I was afraid of aspirating and things that came along with it, vitamin depletion and things. But I've learned through the gastroenterology people that sometimes mineral oil, especially on a short term or a low basis, is something good that you can use. You just need to know a few things about it. You shouldn't take it last thing before you go to sleep at night because of the aspiration problem, and you should use a multivitamin at an opposite time of day if when you're using the mineral oil. One easy way, the people at Scottish Rites in Dallas shared this recipe with me, and I use it a lot with my cerebral palsy kids as well as with my spinal bifida kids that just need a little something to make it easier, or kids that have had fissures that have that it's been painful for them to go to the bathroom and they kind of withhold when you're trying to work with them, and it's just ice cream and pudding and mineral oil, and you mix it together and freeze it, and then you give it like by the tablespoon, and you can do strawberry one time, you can do chocolate one time, you can do vanilla one time, but it's a safe way to get mineral oil into kids if it's somebody that has to take it on a regular basis. And you can titrate it. You can give a lot and then you can back off and get it What the mineral oil does is to lubricate and make it go through, so that if you have somebody that, especially if it's painful, I have kids that they scream when they go to the bathroom, and then we're trying to desensitize them. It's just a way to get everything to slide through. Did you know how you have breath strips? Well, now you can get sinus strips. I was just kind of enthralled when I went down the laxative aisle this last little bit. It says, uh-oh, Garfield wants in. It says, wham, wham, wham. When I want in now. And that's the way that orals do. Oral medications, particularly stimulant laxatives like Ducalox, Senecot, X-Lax, can't think of all of them, Bisacodyl. You take that through your mouth, and see, a lot of my teenage girls says, I just want to take a pill, or I just want to take something by mouth. And I say, well, you can do that. You can take something by mouth, but it depends on what you eat, how much you move, how much you've got in your system, as to when it's going to come through the other end. It could be 6 hours, it could be 8 hours, it could be the next day, but this is how these laxatives work. Whenever it's time, you can be standing in front of the Queen of England. It doesn't make a difference. It's going to come. So if you want control, you need to do something from below. And when I was talking to the girls at Duke, I had a slide that said "ew," because I know they don't want to. But for control, you need something that makes it happen when you want it to happen. It's like swallowing a time bomb. Take your 2 Ducalox and just wait. You don't know when, but it's coming. And that's not a good control for your bowel program. I have people that stay home all weekend and take laxatives, stay home all weekend and just wait for it to happen and then go the next week. That's not living your life, particularly when you're a young person. I don't want somebody staying home all weekend. Things like citroma or I can't think of the other name for it. Yes, it starts with a C. Yeah, mag citrate. We try not to use that except for dire, clean out, rapid when we need them, but it should not use things like that on a regular basis. And you really should try to get off of the other. Miralax, do you know that they told me that in the Southeast we are the biggest Miralax prescribers in the whole country? I don't know if that's a dubious honor or what, but Miralax is a very good drug. It's easy to take. It's easy to get in people. It is excellent for clean-outs. It is not so excellent for maintenance because it's very hard to titrate. It's like, I have families will come in and they'll say, they'll go to the GI doc and they'll put the x-ray out and they'll say, this is great, it's wonderful, you're all cleaned out, you're not backed up at all. And they go, this is not wonderful, I have stooled continuously, since I started taking the Miralax. And I have a few families that have been able to titrate it, to get it down to a teaspoon, which I'm not sure is doing anything, or whatever, and they feel like that they've got it going, but by far, the most of the people that I work with, Miralax is not for continence. It doesn't help you. It makes you stool a lot. The other thing I would like to warn you is you need to be careful what you're buying. You need to read what the ingredients is because X-Lax and per diem used to be fiber plus a little natural senna in it. But it's not that anymore. It's exactly what X-Lax is. If you read on the senna sides, it's exactly like X-Lax. On the other hand, Dupalox I've always thought was a stimulant laxative. It's a brand name evidently because this is milk of magnesia that has the Dupalox label on it. So you need to know what ingredient that you're having because things are beginning to be a little confusing if you just take a glance at the bottles. I want to move from stool consistency and that to timing and how you get control. I'll talk about the surgeries. I'm not going to talk about the surgeries like Dr. Joseph talked about the surgeries because I don't do the surgeries. I help manage the things afterwards. But there's literature proof out there, and it's evidence-based practice, which is a big buzzword in medical circles, that the ACE and the MACE procedures have helped people be continent more than anything we've come up with, in the last decades. What I also know is that out in Texas, they decided that, and they decided they were going to just give everybody ACEs and MACEs. And so they started doing a large number of them. And they had people that let them close up. They had people that it didn't work well on. They had people that didn't like them. They had people and all the other. And then they kind of backed up and said, maybe it's not for everybody. It has to be the right time. And it has to be that the child knows what is going to happen, the parent knows what the commitment is. If you start just saying ACE is it, then you're going to, it's misleading. I have people in my population, and they're young adults now, but they grew up, that use a Dupalox suppository every other night. They have very few accidents. They do well. It doesn't take them long to do their program. They'd be crazy to opt to go have a surgery that they have to spend 45 minutes or more on the toilet for them. On the other hand, if you're trying to use a suppository and you're trying to use an enema, and you're always not getting the level of continence that you're working for, then the ACE is something that usually will give you that level. And so it's not as simplistic to say everybody with spinal bifida should have an ACE, because that's not true. Everybody that has spinal bifida that doesn't have bowel control needs a program that will render them clean and give them the self-confidence to participate in life, whatever that is. And we're going to go from the least invasive to the most invasive. The least invasive is what we call habit training. It's just being able to go and sit and push and go to the bathroom. And some of the kids, if they're put on the toilet after breakfast, after lunch, and after supper, actually develop a pattern, and they know, and they do very well. Usually it's what they belong to compulsive parents that have, since they were little, been having them do that. Doesn't mean that everybody can be compulsive enough, because if it were, I would tell my parents, if you'll be compulsive enough, it'll work, and it's not true. But there are children who don't have to do, and that's the ultimate bowel program. You know, nothing to buy, nothing to do, nothing. You just have to make sure that you sit and do your program. Now, if you're going to have your child sit, you need to be sure that their feet either touch the floor, or you give them a stool or something to put their feet on for counterbalance. Now, if any of you want to do a little experiment, then the next time you go to the bathroom and you're going to have a bowel movement, I want you to pick your feet up off the floor and suspend them in the air and continue. You're gonna, now you have enough muscles that you can kind of stretch and do that, and I can do it, but it's not easy. And people who already have weak muscles and are paralyzed need gravity and all the help that they can get to help them do that. They need a counterbalance for their feet, and they need to actually have their knees up a little bit higher than their pelvic floor if you're really going to help them go to the bathroom. So no matter what method you're using, you need to make sure when they're big enough and their feet touch the floor, it's not an issue anymore. But don't leave them dangling, and for them to give you their best effort. With little kids, you can teach them to push. Some kids come into this world knowing how to push. Others don't. Some kids have to learn how to push. You can have them blow bubbles. You can have them blow pinwheels. You can have them do the Hulk. You can have them do whatever to try to get them to learn how to push. Little kids, you can pull their knees up and have them push and kind of work with them to show them how. But knowing how to push is very beneficial for bowel management. So habit training can be sitting after a meal. After a meal is the best time that your program will work, or that, because you've got the gastrocolic reflex. If you don't know what that is, it's when you eat something, it starts the peristalsis, or the waves through your system. If you've ever had diarrhea or been sick and thought you were over it, took a sip of water and felt that, and then, ooh, I wish I hadn't done that, and that's going to set me off again. That's that reflex that's more pronounced when you're little, but we keep it all of our life. And so the time when you're most apt to be successful in going to the bathroom is after a meal. So if you're trying to get a pattern going, sit. And the other thing is, you shouldn't have your children sit a long time. 5 or 10 minutes and try to push, 5 minutes and try to push is better than sitting a half an hour reading stories and watching a video and doing whatever else and not trying. And then they'll get to where they don't want to go and sit, because it's going to be this long, drawn-out thing. So you want to keep a positive thing. So if you're going to have them sit and try, have them sit briefly and really try, and then get up. Whether they go or they don't go, you let them get up and go. Giving external rewards to your children when they participate with the program, or when they have a stool, or if you're habit training when they have accident-free days. It's like, you think about reward for going to the bathroom, and you say, nobody, parents will let me, well, I didn't give my other children rewards when they went to the bathroom. Why would I give my child with spinal bifida a reward when they go to the bathroom? I said, but your child that can feel gets a reward every time they go. You all get a reward every time you go to the bathroom. And you might not consciously think of that. Now, sometimes you do, because sometimes you go, oh, that's a relief. And you get it, and you recognize that's a reward. But even when you don't, there is a good feeling after you go to the bathroom and get rid of that or whatever. You get immediate biological feedback that you've done something, and it's a good thing. People who don't sense don't get that. And so when they're little, giving them something immediately after to reinforce that behavior, if you're trying to get them on that pattern, helps. Sticker charts are good, particularly with kids that are about 5. And it's interesting when you look at habit training between 5 and 6 years of age. You'll go along like this, and they'll be going about like this, maybe getting a little better. And all of a sudden, between 5 and 6, there's this increase, if they're going to be able to do it, that they are aware and that they can help, and that they feel a little feeling in their tummy they think they might need to go. And they're also in school where other people are, and they're aware of it and talking about it. And that's just the perfect age for sticker charts, because they will work for stickers. Because the sticker signifies that they have making progress, that they're accomplishing something, that they're being recognized for their efforts. And sometimes you don't even have to have anything for stickers. You know how you say, well, I would say, I'm collecting these stickers, and what do I get? If I get 5 stickers, do I get something? Some of the kids don't even care if they get anything. They just want to see that affirmation go up there. Other kids, you can say, get 5 stickers and have an accident-free week, we'll go to McDonald's. You know, don't make it anything big, but try to have little rewards along the way for that age. Of course, if you get a teenager, they're not going to buy into that unless you're going to get them like a Wii or something if they do. Which by the way, Wii is a phenomenal tool for your kids to for their exercise and things. We had a young adult conference and we introduced them to the Wii because the bowling and the moving, they moved more than I've ever seen that group move. And we're actually trying to find ways that we can either raise money or get some grants or something to get more Wiis to place in their homes. Digital stimulation is another, if you're habit training, the next thing is digital stimulation. And that is just taking a gloved finger that's lubricated and circling the anus that causes, you know, that relaxation so the stool can come down. It does it from below because the cord's not working, basically. Spinal cord injury population is big on digital stimulation. The people at Shepherd's and me kind of went back and forth with it because they just took the tack 20 years ago, and I don't even know who's there now. But 20 years ago, they said digital stimulation will work for everybody if you do it right and you do it enough. You don't need anything else. And I kept wondering why they kept saying that, because it didn't work that way. And then I got to thinking, people that have spinal cord injuries have normal patterns established, normal pathways, normal patterns for bowel before they're hurt. And it's just like tapping back into that mechanism, and the body remembers, and it does. Spinal bifida kids don't have that to start with. They don't have anything to tap back into. So digital stimulation doesn't work as well or exactly in the same way. Digital stimulation is cheap, and it's easy, and it's okay. Most of the time, especially my teenage girls, don't like it because they think it's distasteful, and it doesn't work as well, to be truthful to you, as other programs do with the spinal bifida population. The next thing you can use is baby lax or liquid glycerin, and that's a PD lax. That's a new version of it. I make what I call a homemade baby lax, or poor man's baby lax. I just use a 14-French catheter cut off on the end of a syringe. And the reason that I do that is not only cost and a bottle of liquid glycerin, is the fact that you can get the glycerin higher up. A lot of times my parents would tell me, well, when I try to do that, I put the liquid glycerin in and I squeezed the bulb and it just came right back on my hand. Well, you've wasted how much ever it is. It's like $4.49 for 6. But it doesn't help go to the bathroom because it's on your hand. It doesn't help them go. But if you have it where you can put it a little further up and put it in, then it lubricates and it irritates the wall just like a suppository does and helps you empty it one time. Kids that I have that aren't real constipated, that we're just trying to pattern, just starting in potty training, a lot of times I'll use the liquid glycerin with them. They just need something to kind of start it, and then it comes. With regular sitting after meals, or at least once a day, we'll use liquid glycerin. Enemies is kind of the next step up. It's just Colace and soap is all that is in a disposable. You snip the end off and use it. Spinal cord injury population also uses this more than spinal bifida, but I do have some kids that use this. It's also, you need kind of a formed stool to use that. If you go to suppositories, there's glycerin suppositories, there's Ducalot suppositories, there's really CO2 suppositories and other kind of suppositories, but mostly we use either the glycerin or the Ducalots. There is a product out called the Magic Bullet, and it is a water-based Ducalot suppository. If a Ducalot suppository works well for you, but it just takes a long time, like you say, it really works when it works, but it's taken an hour before it works. And so we're like putting the suppository in right after supper, but it's an hour before it's working, but then it works well, then you'll love the Magic Bullet, because the Magic Bullet is water-based. It just happens faster. But if a Ducalot suppository doesn't work at all for you, the Magic Bullet probably won't either, because it's the same medicine, just in a different base that melts faster. You can get these at the drugstore some places. You can't where I live. You have to get them by mail order. They're very reasonable. A fellow invented these that is in a chair himself. The next thing is small volume enemas like fleets, mineral oil fleets, things like that that give you a little more bulk to have a bowel movement. There's one that I particularly like. It's Vesicodil or Bisacodil, however you want to say it. A regular fleets is 4 ounces. These are only 1 ounce. They're about this big. They have a Ducalot suppository dissolved in them. They usually work quickly and they work well. I use those a lot for my pre-ops because you don't have the danger of absorbing the phosphate from the regular foods. But you just need to know about them anytime. Sometimes if you really got in a fix and you got backed up or constipated, that's a very safe thing to use that usually gives you good results. This is a cone irrigation enema. It's actually a colostomy irrigator. Now this is when we say off-label use, and I'm supposed to say this is off-label use because these are not manufactured to use like we use them. It's a very safe thing that we use them for. We just use it to deliver a large volume enema while you're sitting on the toilet. And what you do is you just fill the bag up and you use fairly large volumes. It's 20 cc's per kg, and you just warm water. You take the cone and you put KY jelly on it, and you sit on the toilet and you use it kind of like a stopper in the rectum, and you turn the water on. The water flows in and kind of does what Dr. Joseph was saying, a left-sided washout, and then back down in the toilet. When I first heard about this, and we were talking about it at National Conference, I thought, that's what I'll use on my kids that are really constipated, that really don't move around a lot, that that are really hardcore, that they need something like a left-sided washout. What I hadn't counted on was the other end of the spectrum. I use this as an introduction, whether they are thinking maybe they want an ACE or not. It's a wonderful pre-ACE piece of equipment because it mimics your ACE procedure somewhat, and it lets you know kind of what kind of problems you're going to have and what the commitment is. But the kids that I have that are active and that have multiple stools a day are the kids that I recommend using this with, because it's been the thing that's given me such good continence with them. I had one little girl, and I'm anxious to see if she's going to get an ACE or not, because she's just been hanging with this program. Started it with Claire when she was about 6, and she is in the 10th grade now, and she probably has had less than one hand accidents on 5 since she started with the program. When it works for kids, it usually works very well. And what it is you just let the water run in fast, take the cone out, and it'll go swoosh, and in a little bit it'll go swoosh, and in a few more minutes it'll go swoosh, and in about 20 minutes it gets quiet. It's so funny because different kids can empty in different times. Some kids can empty in 15 minutes. Some kids it takes more, like a half an hour. But the interesting thing to me is they all know, and their parents know. And when they're in-house and we're doing something, and I'll say, do you think you're through? And they'll say, no, I'm not through yet. And I go, okay. And then we wait a little bit, and here comes some more, and they know. Or the parent will say, I don't know, let me see. No, they're not through. So they begin to know, and they begin to sense, and they can tell when things get quiet again and they're done. And some of them have a backwash during the night. They call it backwash because they'll have a little bit of mucus or a little bit of water that come out during the night. But usually by morning, they're good to go for 2 to 3 days, depending on the program. I have people that do it Monday, Wednesday, Friday, take the weekend off. Monday, Wednesday, Friday, take the weekend off. I have people that do it every other, and I have teens that do it every third. If you have good results and you don't have accidents, but 3 is my limit for health reasons, for cancer risk and things like that. You really shouldn't go ever more than 3 days without doing a program. People that are thinking about the ACE, we introduce this to them, and it kind of gives you a feel about how much it's going to take and the commitment, because you don't want to have surgery and then find out that you thought it was going to happen in 15 minutes. And it didn't sound that bad, but if it takes 45, you're just not in for that. It's just a good, and if the cone works good, the ACE will work better. If you have trouble with the cone, you're going to have similar troubles with the ACE. If the trouble is that you've got a tight sphincter, that's going to be whether you're using the ACE or the cone. And so it's a sort of a way to work out a little bit of the kinks preoperatively. This is a picture of an ACE, and this young man does his program himself. He has, I like the VisiFlow bags because it has a water wheel in it, and you can see when the water's flowing and when it's not, especially if they're doing it themselves with nobody watching. If you're a nurse, you know how you do when you're giving an enema, just a regular enema. You'll look up at bag and you'll say, yeah, it's going in. Yeah, no, well, no, I don't know if it's going or not. Yeah, I think it's going in or not. And then in a little while you go, that water hadn't moved, it's not going. And so if a child is doing it themselves, they would have a hard time knowing if they needed to shift their weight or something, except for this water wheel. And when the water's going, this spins. So you know if it's spinning that the water's flowing. And I think that's a nice help. His mother bought him this handheld Game Boy type thing, and the only time he's allowed to play with this is during his bowel program time, which makes him a lot more amiable to go do his thing down, because he can't wait to get it and get it in there and get it going and take it out and then say, give me my Game Boy. Sarah told me, she lives in North Carolina, she told me, she called me and she said, guess what? She said, what SATs, it's whatever you take in middle school, but her testing that they do, standardized testing, she says, my reading scores, she said, took a huge jump. And she said, my teacher couldn't believe it. She said, I wasn't telling her why, because she said, I do my reading while I do my bowel program. So I'm doing very consistent for longer lengths of time for doing my bowel program. I tell parents that if they can get a tray or a table that will come, or a tray that they can put on to do their homework, if you can get all of your stuff done sitting there and getting your homework finished when you're doing your ACE or your cone or whatever, then your time is really free when you're done. You really can do anything else. And so sometimes we'll do that and try to kill two birds with one stone. This is something that I've used lately. It actually can be used for the Mitrofanov catheterizable stomas if need be. We were having trouble on 2 counts with our ACEs and with our catheterizable stomas with them wanting to close up. And they'd say, well, you know, at the skin level. And they said, you know, even if you don't do your program, pass the catheter in every day, even if you don't do your program but every 3rd day, to keep it open. And they were having trouble, and then it would get stuck together, and then it would bleed a little bit. And then I have kids that they don't like it when it feels like it breaks through that, it makes a little crust and all. And so I was talking to my surgeon, and he put me in touch with a mother in New Zealand, and her name's Rosemary. And she devised these little silicone plugs, and they're very flat, so they lay very flat against the skin. And she calls them ACE plugs. And they're not FDA approved or medically approved or anything, because she said I had not nearly enough money to get through all those hoops. But the surgeons look at them and they say they're safe, there's nothing that will cause a problem or whatever. They're $20 a piece. And I ordered them and just paid them for them myself, because it's so complicated trying to get something from New Zealand. And she said, you can use PayPal or you can just send me a check or whatever. Well, the hospital wasn't into PayPal, obviously. So I said, well, I'm going to get 2 and see if they work. So I got 2. And they really helped the girls that I got them. And so then I got the hospital to order me some of several sizes. She only has 8, 10s, and 12s. But what they do is after they finish the program, they just insert this little soft silicone flat on this end plug and put a little non-latex Band-Aid over it to hold it in, and then it keeps it open during the time that it's healing. But there again, no news. It was a mom that has come up with a solution to help these kids. You can also have things done that have buttons. This is a left-sided that goes into the sigmoid. You just flip open the top, almost like a G-tube, and put the end of a tube in from there. The left-sided procedures are supposed to be quicker because you're only flushing just the left side out. But there's been one problem that I have had with the left-sided procedures, and that is that part of the bowel is much more mobile than where your cecum is up here, and it moves that tube in and out. And I've had some complaints with some kids that it was uncomfortable, and I've not had anybody complain with the right-sided procedure saying that they're uncomfortable. So that's just been my experience. There might be a better tube or a better way of doing it, but people do right-sided and left-sided procedures. Biofeedback, I want to mention in that there is a select group of kids that would benefit from biofeedback. You have to have some sensation to be able to do that, and you can do anelometry, where they put the balloons in to see if you have any sensation and work with that. And then it's like a behavior modification, learning to sense different things. I don't do biofeedback. It has come back into vogue. It was in vogue several years ago, and then it kind of fell out of favor, and it's made a little resurgent with the bladder stimulation and the other things that are coming. There are many choices for timing, but the bottom line is that you have to do it. Nothing works if you don't do it, and you don't do it regularly. It is not for the lazy. Bowel management, as long as you eat, you're going to make stool, and you have to do it. And that's one of the worst things about it. One thing that had become clear to me this last year is that if you neglect your bowel health over a period of time, you can get into a lot of trouble. I've had 2 young people that obviously are still under 18 because they're my patients, and we just follow kids till 18, that have had to go in and have part of their bowel resected because they had such stretched out, chronically constipated systems that even trying to flush an ACE through them, we couldn't get them to do, and they were physically in the hospital and ended up having to have surgery and resection for that. So it's not like something that you can just ignore and it'll go away. You ignore it and there are penalties for that. One thing I wanted to mention is that if you think your child's having diarrhea, you need to make sure they're not really constipated. 9 times out of 10, they'll be constipated with liquid stool coming around hard stool. One of the ways that you can tell is the amount of diarrhea that you have. If you have diarrhea that comes out and goes up your back, that's not leaking around an impaction. But if you have just liquidy stools constantly, then the very first thing you need to suspect is that you really have an impaction, and you give an enema or take a laxative, which you'd say if somebody saw you on the street and said, oh, you have a problem with diarrhea, that's smart to get an enema and take a laxative. But if it's from an impaction, you need to try to get that impaction moved out. Sense markers are one way you can look to see how you're doing with the bowel program. I learned this from the PEDS GI people. It's a little capsule that you swallow, and you take a flat plate 5 days later. And the I don't know which slogan, whatever, goes like this: 95% of the people pass 95% of the markers 95% of the time. And so if you take that and you see that you still got rings, there's 24 rings in that capsule, if you still got rings, and sometimes I can tell where my problem is, like I can give a child a sense marker and look, and they'll all be kind of clustered in a certain area, and you know that's the area that's not moving through. Or you'll see that they'll just be sprinkled all throughout the system, which means their whole system is just slow. A lot of times if a parent says, I don't think my child is that constipated, then I say, well, we can do a sense marker test and see, and they're amazed at how what they ate 5 days ago is still in their system when you should be looking at 24 to 48 hours. Another thing that you can do, and this was the picture that I took when we were trying to do this, is that I had a child that we had him on a good program, but we wanted to make sure that we had him on a good program. And so what we did was we got the program like we thought, and then we did a second test to see. And although the markers are still in there, they are all getting ready to come out at the same time according to his program, and he was on an every 3-day program. So we could kind of trace to see how things were moving along. There are things out for odor control that you can get odor out of things with. Somebody from Alabama actually told me about this spray. They said their kids' braces had gotten to where they couldn't get the smell out, and so they took them, sprayed them with this, put them in a garbage bag, and closed them up all night, and then when they got them out the next day that they didn't smell anymore. I just passed that along for what it's worth. I passed it on to other people, but actually originated in Alabama. Nullo is an internal deodorizer. You get it over the counter. It's not to replace good hygiene, but sometimes if you do, and I said there's some people at work I'd like to slip some of these to because it deodorizes breath, sweat, stool, feces. It's just like an internal deodorizer. And you remember the Clorettes, the chewing gum? This is just a concentrated Clorettes, and you just chew 2 of these Kelly Green tablets with meals, and it deodorizes things. And so if you're going through a time when you're having trouble and you're really trying to lay low and not draw attention, sometimes something that takes the odor out of the stool is helpful. There's also fancy things like all kinds of contractions to help with your tortin. It's as simple as the little rings. You know, a lot of the kids with spinal bifida have very narrow pelvises. That's little rings that they make for potty training. You can put them on and take them off really easy. The bottom line for bowel management is life is like a poker game. If you don't win, you lose. And you can't win if you whine instead of work. And you can't win if you smell bad. But if you just adopt the just do it, Mikey says just do it. And they're talking about exercise and those things for all of us. Your bowel and bladder programs are like that. There's one thing that I wish for the young people that I work with is that their bowel and bladder program is not the focus of their life, that they just do it and get on with their life. This is an office mate of mine. She's not an office mate now, but she was an office mate for 7 years. And I learned something from her. This is Janine. Janine is a severe diabetic and has been diabetic since she was like 3 years old. The 7 years that she was my office mate, she did not miss one day of work from being sick. Not one. I had never known a brittle diabetic that had done that. And I said to her, how do you keep from, getting sick and your sugar going up and whatever? And she said, there's a lot of diabetic and a lot of diabetes in my family. And what we've learned and passed down and told each other was, if you don't want diabetes to ruin your life and run it, then you do what you have to do to stay out of trouble. She said, I check my blood sugar when I get up in the morning, I check it mid-morning, I check it lunch, I check it in the afternoon, I check it at night, I adjust my insulin. This is before she got an insulin pump during the time she was there, but when she was given injections, no matter what was going on, no matter where she was, no matter what, she just was committed. And I didn't even know she was doing it. She'd disappear into her office and she'd come out in just in no time, and I didn't know she'd gone, stuck her finger, read her thing, and adjusted her insulin and come out again. She had to do that to stay healthy, but that's what she did. And it didn't ruin her life. I didn't even know she had diabetes for the first few months that she was my office mate. And that's the way bowel and bladder is with spinal bifida. If you start early and you work to keep from getting constipated and keep in a good stead when you're little, and through the growing years, start early to try to have a good program. Then as you get older and as you begin to take on responsibilities for yourself, you'll be able to do that. I love this picture because these are 3 guys with fairly high-level spinal bifida. But when I look at that picture, that's just not 3 guys, it's 4. That's 4 guys. I mean, that's 4 guys, and the spinal bifida is way in the background to me because they were having a ball, and they should. This is our chief of staff now. He's a little older. But the take-home message for this is a motion analysis study, $1,900. Orthopedic surgery, $10,000 to $50,000. Not soiling myself in front of my peers, priceless. Thank you.
Thank you for attending this session. Because meeting your needs is important to us, we need your feedback on this presentation. Please take a few moments to complete our evaluation, which can be located by clicking on the presenter's name located to the left on your screen. It will only take a few clicks of your mouse to provide us information to make the SBU experience better for you and others. If you have any questions relating to SBU, please contact us at sbu@sbaa.org.